Yeah, my fascination with orthopedic surgery started when I was 15 years old on a football field when I fell and broke my wrist. And that required going to the operating room to get the wrist reduced or put back into place with the 6 weeks of a long arm cast, which at that time was plaster. I'm telling how old I am, but learned to drive in that cast. So in the process of treatment for my wrist fracture, I became friends with the local orthopedic surgeon who was treating me and was able to go into the office with him and go into the hospital with him, and it kind of really fostered my interest in orthopedic surgery, which led me to where I am right now. I do a wide variety of knee surgeries, everything from simple knee arthroscopies for cartilage tears to total joint replacements in the appropriate patients. Do ACL reconstructions, meniscal repairs, PCL reconstructions, multi-ligament knee injuries, cartilage restoration. Pretty much try to do everything I can to maintain the knee in the anatomic state prior to doing a total knee replacement. I see a lot of weekend warrior athletes. I see a lot of the high school aged athletes. I see a lot of people who are competing in marathons, triathlons, a lot of stress fractures, a lot of random injuries. That's the good thing about sports medicine, is you get to see a variety of injuries and a variety of patients with different presentations. Big believer in physical therapy. I will typically maximize physical therapy and maximize non-surgical treatment prior to consideration of surgical treatment of a particular injury or a particular problem. After knee and shoulder surgery, typically, as I said, 3 out of 4 patients, if not even a little bit more, will be enrolled in physical therapy. We have a physical therapy location in both of our offices in Hoffman Estates as well as Elk Grove Village, which allows us to better monitor our patients as they're enrolled in the physical therapy. Typically we get reports from therapy, and we'll, with each successive office visit, decide if the patient would continue to benefit from physical therapy or if they have advanced to the point where they can direct their exercise program on their own at home. We have a state-of-the-art 1.5 Tesla MRI scanner that has a large bore in the neighborhood of 72 inches that will allow claustrophobic patients and larger patients the ability to get a much better detailed study compared to some of the open scanners that are 0.3 Tesla that are available in the area for those claustrophobic people. In addition, we have a little bit more flexibility in after hours and getting patients in much more to their schedule and what their schedule would desire than a hospital setting typically does. When it comes to the time for surgery when non-surgical treatment options have failed, typically we will talk about surgical treatment of a particular problem, which would entail, for the vast majority of people, outpatient surgical treatment. And after the surgical date, a period of time will pass and we'll get them in physical therapy. Probably 75 to 80% of my patients post-operatively will benefit from physical therapy. Pain management is a very important part of the procedure. So during the procedure, I and my colleagues have started injecting into the lining of the knee joint a cocktail that entails some anti-inflammatory medication, entails occasionally some steroid medication, and some numbing medication that makes the early post-operative period much more comfortable and has resulted in our pain requirements in the patients dropping significantly, which is very important since we began the rehabilitation on the first day after the surgery. I'm very excited to be a member of Core Orthopedics and Sports Medicine. I think we are a very unique practice in this market in this day and age. After being in a large practice, it was very exciting for me to be a partner in a smaller practice, to have much more governance and say-so as to the day-to-day operations of the practice.